Thank you for the kind introduction, Alexander, and thank you, AJ and Dina, also for the kind invitation. Now, non-invasive risk stratification, and I will try to be complementary to what Professor Lumba already discussed this morning. The risks we are talking about is, of course, the risk in terms of liver disease. That's what we also very well know. But we also have to take into account, thank you. We also have to take into account the extrahepatic risk. So we have the increased risk of cardiovascular disease, kidney disease, extrahepatic cancers that we have also to encompass in the risk stratification. Now, this field has been shaped by histology, as we all know. So histology is also there for risk stratification. This is a famous cartoon showing you that fibrosis is important to predict prognosis, both for liver-related complications as for all-cause mortality going up from F2 onwards. So fibrosis is important in terms of risk stratification. Although we also need that the true driver of disease progression is, of course, the underlying inflammation and damage, so the underlying steatohepatitis. So if you have steatohepatitis, you double your speed of progression in terms of fibrosis stage. If you have steatohepatitis, your odds ratio of cardiovascular disease is also increasing. So it's the underlying MASH that is driving a disease progression. That is what we should start off in terms of thinking about risk stratification. But of course, it's not easy because the natural cause of the disease is not linear. So the concept is that steatohepatitis, the driving force, is waxing and waning. And so also the fibrosis is progressing not with a linear course, but with an undulant course. And so predicting prognosis with a single measurement at one time point is not that easy in this disease. If we do it with non-invasive tests, there are different approaches. You can, of course, use the non-invasive tests to make a diagnosis of the histological lesions. So you predict prognosis via histology, and that's the diagnostic context of use of those non-invasive tests. But as we have also learned from Professor Lumba, some of those NISDs are predictors of prognosis without necessarily correlate them to histology. So that's a different context of use, is the pure prognostic context of use of those non-invasive tests. And then, as I said, prediction with one single time point measurement is not that easy. So there's probably an added value if you do multiple time points measurements. And the question is, does that refine the prognosis calculation or not? As terms of surrogates for liver histology, that was nicely covered by Professor Lumba. I will not come back to that. I just want to add something about fibrosis. And then the entity of at-risk MASH. Again, it's not just fibrosis, it's the underlying also disease etiology or activity that we have to take into account. And of course, we don't have good NITs for steatohepatitis as such, but we are making progress in identifying patients that have active steatohepatitis and at least F2 fibrosis at the same moment. For fibrosis, this large meta-analysis from the Litmus Consortium clearly shows you that around a large array of different biomarkers, if you have large populations, most of them do not hit the 0.8 ROC cutoff for the diagnosis of advanced fibrosis. But there is some progress, of course, as you can see here. Liver stiffness by VCTE does hit that target, but probably we can improve. And one of the improvements is, of course, with all the omics technologies that we have. And this is a very elegant study from the group from Newcastle, showing that there can be a relation between some of the proteins that you measure with proteomics in the serum and their expression profile in the liver. So really linking what you measure in the serum with what is happening inside the liver. And that's one of the ways to go forward, really linking what's happening inside the liver with what you're measuring in the blood. And indeed, one of those proteomic approaches, like SomaLogic, goes beyond the diagnostic accuracy of many of the other biomarkers we have so far in diagnosing advanced fibrosis, and in that diagnostic context of use is probably a step forward. As has already said before, also liver stiffness, and I also said it hits also the 0.8 cutoff for OROC for those who like to have those kind of threshold. But if you add it to serum biomarkers, then you also can increase accuracy. That is what has been done with AGILE-3 plus for the diagnosis of advanced fibrosis and AGILE-4 for the diagnosis of cirrhosis. So you have liver stiffness measurement AST, ALT, platelets, diabetes, sex, and also age, and for HI3. And what has been shown is that that increases indeed the accuracy up to an RWAC of 0.9. So that's also, again, a step forward. At-risk MASH, again, all those biomarkers for the diagnosis of at-risk MASH are not very accurate. Again, SomaLogic is one of the best here, but is not above the 0.8 threshold. Some of the recent improvements is with the NIS technology, originally NIS4 with 4 parameters, a microRNA, YKL40, alpha-2 microglobulin, and HbA1c. It has been simplified to 2 markers with a factor correcting for the sex of the patient. And as you can see here, for the diagnosis of at-risk MASH, and again, pay attention to that specific context of use, it outperforms some of the others more readily available scores that we have seen so far. What is also important is that it performs well across the whole BMI spectrum, which in this population is, of course, important. So that's a promising new tool that is further developed now. Coming now to prognosis, NITs as prognostic markers directly. Again, this is a meta-analysis we did with the Litmus Consortium. It confirmed, first of all, the prognostic value of the histology and mainly the fibrosis to select patients and to predict their outcome. But as you can see here, liver stiffness here with the cutoffs of 10 and 20, or the NAFLD fibrosis score, or the FIB4, they do have prognostic value by themselves without linking them directly with liver histology. Also in the study of Vincent Wang's group with consecutive liver stiffness measurements, but just for the baselines, again, the combination of serum and clinical parameters with liver stiffness also had prognostic implications and was the strongest predictor of prognosis in this cohort. And this is a study from the NASH CRN, again showing you, this is a little bit sensitive, again showing you that liver stiffness is predictive of prognosis, and mainly above 10, the prognosis is starting to get worse. Now, this is all one measurement predicting prognosis. What about consecutive measurements over time, and how does it help in the prognosis? We know from FIB4, already from the Swedish cohort of Hannes Hagström, that indeed if fibrosis, if the FIB4 over time increases, it increases the risk of severe liver disease and vice versa. If the FIB4 is decreasing, then it decreases your risk. So evolution over time in such an NIT seems to tell you something, at least in this case, on a large cohort base. Liver stiffness measurement, one of the first studies to show you here that changes over time may tell you something, is the cohort of Salvatore Petta, showing that with a 20% increase, their threshold was 20%, over time you have an increased risk of both liver-related events as well as overall mortality. And if you are on the left-hand side, you have a decrease of 20%, the gray bars, then you see that the prognosis is better, both liver and overall mortality. So far so good. Again, the study I already showed you from the NASH CRN with the 10 kilopascals threshold. What you can see on the left-hand side is those that are below the 10 kilopascals at baseline, if they remain below 10, they have the best prognosis. Those that increase above 10 clearly have a worse prognosis on the, in terms of liver-related event in this case. On the right-hand side, you can see that those that start with a value above 10 but decrease below 10 on follow-up have a better prognosis compared to those that are still above 10 when they have their second assessment. And this is an update of the study of Vincent, which was presented at the ALC in Milan lastly, showing you again, if you do repeated measurements and they used 10 and 15 kilopascals at different cutoffs, some people change from category over time. And most importantly, again, if you have an increase in liver stiffness, it corresponds with a higher likelihood of developing liver-related events. Vice versa, if your liver stiffness goes down, there seems to be a lower risk of liver-related events. Again, showing you that having consecutive measurements and following the evolution over time refines the prognostic information you can retrieve from such a marker. Another important risk factor when we come to more advanced disease is, of course, clinically significant portal hypertension. And also here, there is some progress made in terms of non-invasive tests. This is a study that we did with a large group from the Baveno Consortium. And first of all, we have the most recent Baveno criteria with liver stiffness 15 threshold and the platelets 150, and then the 25 liver stiffness threshold, being quite accurate in diagnosing CSPH, but with a quite substantial gray zone. If you then use spleen stiffness with HVPG as the gold standard, you get, with the thresholds of 25 and 55, you get comparable sensitivity and specificity, but you already reduce the gray zone. And if you then combine both, then again you have good sensitivity and specificity and even further reduce the gray zone, so you increase the accuracy of the approach and the prediction of CSPH. So we are coming to a kind of anticipate NASH model approach. In the anticipate NASH, it was liver stiffness measurement, platelets, and BMI. But if you add spleen stiffness to it, if it's technically feasible, then you increase the accuracy of predicting the presence of clinically significant portal hypertension. And as you can see here, it outperforms indeed the anticipate NASH model in this cohort. Just a word of caution. In the MESLD space, clinically significant portal hypertension as measured by HVPG might be an underestimation of the true portal pressure, and even those below 10 millimeter of mercury do have a risk of decompensation on the long run, although much lower than those with an HVPG of 10 or more, but still it's something that we need to take into account and which seems to be different from other etiologies like alcohol-related liver disease or viral hepatitis-related disease. Finally, a few words of limitations about interpretation. This is already a very old cartoon about FibroScan liver stiffness measurements in patients with viral hepatitis, showing that there is, between the different stages of fibrosis is identified by histology, a very large overlap. And that's very important for the wording about this result. You will not, or you cannot use it to just say to a patient you have an F2 or an F3. It's about the likelihood of being in a certain category above or below. It's not a precise assessment of the stage of fibrosis, and that is a first important thing in the communication with the patient. Also, the variability of tests is something to take into account. This is just for ALT within subject variation. So you measure it at 2 time points in the same patients with not so much time in between. And as you can see, the variability is in between 10 and 30%, which is quite substantial if we want to make a comparison over time. We also know that for liver stiffness, this is a study again from Vincent Wong's group, high liver stiffness measurement as an indication for liver biopsy. A few weeks later, the patient comes back to perform the liver biopsy. VCTE is repeated. The high value is confirmed in 2/3 of the patient, but is not confirmed in 1 out of 3 of these patients. And also this study was already alluded to also yesterday by Arun. He was also, I think, the last author on this presentation of 2 years ago on the ILC, where the variability of liver stiffness with shear wave or with VCTE was tested in patients with measurements on the same day and by the same operator, but also on different days by different operators. And as you can see here, in terms of variability, different day, different operator, it's 30%, 35% for VCTE. But even same day, same operator is 20%, 21%. So if you want to interpret correctly and also communicate to the patient correctly what a change over time means, we have to take that into account. This brings me back to the study about FIB4, which nicely showed that if FIB4 over time increases, there's a higher risk of liver-related events and vice versa. Yes, very nice. But in this study, 50% of the patients that on follow-up developed severe liver disease had a persistently low FIB4. And also, 1/3 of the population had, somewhere in follow-up, elevated FIB4, and the vast majority of them never developed any liver-related event. So it shows you that for some of these parameters, if you have a large cohort and a big population, then statistically, yes, you see some things that might help you in the interpretation of these tests. But for the individual patient, or what it means in the individual patient, that is sometimes very tricky, and we need to be very careful in how we interpret it ourselves and also how we communicate it to the patients, because it can cause a lot of anxiety with patients if, or false reassurance if it, in the case it goes better, of course. So this brings me to my concluding remarks. First of all, I think there's increasing evidence that NITs by themselves have a prognostic value regardless of their diagnostic connection with liver histology. Monitoring those NITs over time has added value in prognostication, but there are many pitfalls. We have to be careful with how we interpret the results and how we communicate it. It's mostly about likelihood of being in a certain category. It's not always a precise prediction. We have to be aware of the test variability, and studies should thoroughly report also on that test variability so that we know with what tools we are playing and what the limitations are, especially when it comes to the individual patient. What does it really mean in the individual patients? And of course, if we do those tests and we see something, we also have to act, we have to do something with the result, and we hope that that then will change the natural history of the disease, which is something that in most instances, of course, still needs to be proven. Some of the improvements I discussed, omics will, of course, change, especially in diagnostic accuracy. At-risk MASH is also an important entity to identify. Liver and spleen stiffness, I think the data are more and more robust about their usefulness in our daily clinical practice, both in cross-sectional diagnosis and in follow-up. And what I did not discuss, but I think it's also important in terms of risk stratification, is of course genetics, but that's a completely different topic, and in the interest of time, I will not touch upon that. I thank you for your attention.